Let's welcome our first speaker then, Dr. Debjyoti Dutta. He is currently working as a pain physician at Samubati Pain Clinic, Kolkata. We would request Sir to share his insight on evaluation and approach to a patient with low back pain.
Thank you for the nice introduction. We need to go step by step to evaluate a patient with low back pain. The problem statement is huge. As I told, it is one of the leading causes of disability worldwide. And if you look at India, where the prevalence is very high, and especially in the scenario of a poor socioeconomic status, where the treatment is even not available, then it becomes an epidemic. And what happens to them ultimately, as it is involving the economically productive group, so we are losing a part of our GDP because of this. Now, if you see 100 low back pain patients, you will be surprised 90% of the low back patients can be treated without any specific medicine or with the help of a little bit of NSAIDs. So what most of the general physicians do, they does the X-ray, check whether there is any fracture or not, and then send back the patient with prescription of paracetamol NSAIDs. And this type of treatment actually helps for most of the patients. But what happens to the rest 10% of the patients? Remember, these patients are not having any big surgical indication for any surgery, but they become a problem in the society and they become one of the sources of chronic back pain. Now, as I told that most of the patients can be healed spontaneously, so what should we do? Can we just wait and watch for the disease to recover? The answer is definitely no, because there are certain conditions which are considered as red flags in low back pain, and if they are present, then the treatment should be initiated as soon as possible. So what are those? So if you are getting patient with possible major trauma, with suspected tumor, with suspected infection, suspected fracture, neurodeficits, autonomic, motor, sensory, so these patients are the red flag signs. Now if the one patient is coming with severe pain, can severe pain be a red flag? So what is your opinion? The answer is severe pain itself is not a red flag. But if it is caused by those conditions, what I am stated, then the severe pain becomes a red flag. So in severe pain, we have to be cautious, but by being only the pain is severe, it is not a low flag. Now, coming to the challenges for the low back pain. Remember, back pain, like other pains, only inflammatory pain which they are, back pain is quite different. Because those I have told the 10% patients is a big problem, so they undergo different modalities like acupuncture and all other normal conventional modalities. 5 to 6% recovers, but rest 5% becomes again very difficult patients. But why they make it so difficult? Because back pain doesn't remain within the nociceptive part, it is coupled with the psychologic part as well as the sensitization component. So what are the diagnostic challenges? Up to 90% of all low back pain patients, the exact source is not known, the pathological mechanism is not known, and you send for an MRI, you send for a CT, there is a poor correlation. This is one of the biggest problem, and as well as the psychological influences that can actually change the intensity of the pain. So let's see what are the generators for back pain in low back pain, pain generators. So if you look at the spine, there are certain areas where the disease affected can cause pain. For example, if you look at the anterior column component towards the anterior side of the spine, we have the disc and we have the vertebral bodies. If there is a compression fracture at the vertebral bodies, that can cause pain. If there is a disc degeneration or disc bulging, that can cause back pain. Then at the foraminal area, if there is a foraminal stenosis or foraminal inflammation, prolapse, that can cause back pain. If you go slightly posterior, there is the facet joints. These are the facet joints. These are the paired joints which join one vertebra with the other. They also carry 10% of each of the load of the back, so they can also produce back pain. Apart from this, there are some muscular structures surrounding that can also cause back pain. For example, there is a muscle which is called the piriformis muscle here at the area. And what happens when the piriformis contracts, it puts pressure over the sciatic, that can give rise to a type of back pain, especially back pain relating to leg pain, that is known as the piriformis syndrome. Similarly, there could be myofascial pain involving different muscle, maybe the psoas, maybe the quadratus, or sometimes maybe the erector spinae, or sometimes there could be ligamentous inflammations like supraspinatus or interspinatus ligament inflammations that can also give rise to a back pain. So our main aim should be finding out which structure is causing the back pain. Remember, when we have failed to look the pain generator with the help of imaging modalities, for example MRI or CT, in that case the pain physicians have a big armamentum, and that is diagnostic blocks. So what is diagnostic block? Very simple concept. If you are having one specific area painful, say a facet joint, what you should do? Just inject small volume of local anesthetic there and ask the patient, are you relieved now? So if it relieves, it proves that joint was painful. But that is not all. There are these type like facet joint block, diagnostic, provocative discography, epidurogram, spinal endoscopy, selective nerve root block, S1, sympathetic nerve block, then differential spinal epidural block. So with the help of all these techniques, we try to find out the pain generator. Now, based on the studies, what are the common causes or source of back pain? Facet. Next comes to the internal disc disruption, then sacroiliac joint, disc prolapse, CRPS. And among the minor causes, it is not minor, but the thing is the ratio at which it is occurring is low, like compression fracture, fibromyalgia, spinal canal stenosis, spondylolisthesis, tumor infection, other causes like FBSS. So they can also produce back pain. In short, how a facet joint pain patient presents? There is pain at the back, pain increases on backward bending, pain increases on rotation, and usually pain relieves on lying down position. Okay? And it is usually absent at rest. Whereas disc has a potential to give two types of pain. One is discogenic pain, where it is caused by the internal degeneration within disc. This is a non-radiating pain or non-dermatomal pain. And one is disc prolapse, where it is giving a dermatomal type of pain prolapse. We all know discs have two layers, the outer annulus and inner nucleus. So what happens in disc degeneration? This outer annulus is having 16 to 25 layer of collagen lamellars. They start first tearing, and when the tear comes to the outer part, then the disc becomes painful, though the outermost part is intact. This is the disc degeneration pain. But what happens when actually this disc after that is getting herniated or prolapsed in the nerve root? That time they causes an inflammation around the nerve root, and that causes a prolapsed disc pain or a herniated disc pain or a radicular pain. Okay? So there is two terms. One is the radiculopathy, one is the radicular pain. Here mostly at the beginning they produces a radicular pain. Now coming to the discogenic back pain. Back pain should be poorly localizing. Patient usually cannot pinpoint one point like myofascial pain, and here the pain will increase with the positions in which the patient's intradiscal pressure is increasing. For example, the patient jumping, the patient sitting for prolonged time, and sometimes the patient while walking prolonged, that also increases the pain. But lying down posture and sitting to standing initially, lying down posture relieves the pain, and initial sitting to standing also relieves the pain. Because while we are still sitting, our spine is curved slightly to the anterior side, so disc over the disc pressure is more. While we are standing, disc pressure releases slightly, so that will also relieve the pain. Now, in the herniated disc pain, that we all know, it's the typical disc prolapse pain. So, it's a radicular pain. It is going through a single dermatome. There will be primarily neuropathic pain. That means there will be tingling, numbness, all the features will be present. And one of the tests that we commonly use to find out those conditions is the SLRT, that actually for the disc prolapse pain, okay, or radicular pain. Now, in MRI, there is a specific entity that sometimes we found in the posterior annulus. Here you can see a pearly white spot. What is this? This is the annular fluid, and it indicates an hyperintense zone within the disc, and this is probably, not always, signifies there could be disc degeneration and discogenic back pain. Okay, I will just take 1 minute, not more. Another common entity is the sacroiliac joint arthropathy, where the sacroiliac joints are painful, and it is also sometimes called a sciatica-like picture, and sacroiliac and piriformis can also cause a pseudo-sciatica-like picture. Here, the patient will complain of pain while sitting, and in other positions it will be usually relieved, and while moving the legs sometimes pain may be increased. Lumbar canal stenosis, basically because of the degeneration, osteophyte, ligamentum flavum hypertrophy. So the lumbar canal area reduces. Patient initially starts walking good, but after walking a little, the patient bends forwards because it's causing painful and heaviness in the legs, and then he is relieved with the stooping forward, which is known as the shopping cart sign, and then the patient continues. Okay, so this is a chart of the low back pain that you can see. I am not going into detail, just take a picture because it will be very, very helpful for you. Okay. So coming to the last part, steps of evaluation. Remember, steps are not different, so we have to find out the red flags, take history, examination, do the investigations, and finally we have to go for the diagnostic interventions. General history component you all know, examination steps you have to go for the step by step. Here special indication is the neurological examination and the special tests. Okay, and this thing everyone knows, so I am not going to repeat it. So what special test, SLR we have already told, it is in the radicular pain, but remember it should be up to 60 degree. If someone is all in pain at 90 degree, it do not have that significance. And cross leg SLR is more significant than the straight leg SLR. Okay, this is a test for the lumbar canal stenosis, which is known as the stoop test and Kemp test. I am not going to detail. And there are a battery of SI joint tests that you have to read to learn it. And this is a test for the piriformis syndrome, which is known as the Fayer's test. So in this short time, it is very difficult to cover in detail everything, but I have given you all the ideas, the areas you need to read to know the subject better. Thank you.
Thank you, Dr. Debjyoti. Very nice.